Good morning, everyone. Yeah, thank you for coming. My name is Theta Ong. I'm the Center Director at Seattle Children's Hospital. And we are just so excited to welcome you to this workshop, Equity in Action. I'm going to introduce my co-chair.
Good morning, everyone. Oh, you say good morning to Theta, but not to me. Good morning. Oh, thank you. I'm Melissa Allow. I'm a clinical social worker at Boston Children's Hospital Pediatric Program and the Adult Center with Brigham and Women's Hospital as well. So thanks for coming to Equity in Action. I'm really excited to see the room as full as it is, especially on the first full day of conference. Here is our disclaimer. Read quickly, it's going away. These are our disclosures for today. So when we think about what is equity in action, Theta and I wanted this workshop to really highlight community partnerships and quality improvement interventions that are addressing the critical issues in health equity among individuals with CF from diverse and often underrepresented experiences. And the main points we wanted to focus on are identifying clinical and research opportunities to address equity among people with CF from diverse and underrepresented backgrounds. I won't say that again because that's a little mumble. Discuss community engagement and potential QI interventions to approach care disparities for LGBTQIA+ perspectives and research participation. And to summarize interventions that consider health inequities in CF newborn screening, CFTR modulator ineligibility, and through implicit bias training and how they may apply to other CF programs. We really wanted to focus today on what people are doing around health equity and access issues, as opposed to just presenting you with data. I feel like we have lots of data, but now we need to know what are we doing with this data. So thank you for joining us this morning. I'm very excited. I'm going to introduce our first speaker today and then give you some directions for after the speakers for questions. So today we are first going to hear from Rachel Salyer, and she is at West Virginia University Department of Pediatrics. She's going to be speaking on perspectives and experiences of LGBTQIA people with CF. At the end of her talk, we'll have 8 minutes for questions. There are 2 ways to submit your questions. You can do that through the NACFC app, which will come up here on the screen for us, but you can also feel free to go to either of the microphones to ask questions. Thank you so much. Let me pull up Rachel's slides.
My name is Rachel Salyer. Thank you for that. My name is Rachel Salyer. I use she, her pronouns. I'm a research coordinator and postdoc in the Gender Research Lab at the West Virginia University School of Medicine. I'm here today to present on Pride CF findings, specifically perspectives and experiences of LGBTQIA+ people with CF. This is the NACFC presentation disclaimer, and I have no relationships to disclose. So Pride CF is a series of health equity team science awards from the Cystic Fibrosis Foundation, and the focal point of that is to understand the needs and experiences of LGBTQIA+ people with CF. You'll see here the conceptual model that Pride CF uses. So we hypothesize that because of minority stress, pictured in the top row of boxes, LGBTQIA+ people with CF are experiencing that. In addition to chronic disease stress from their CF, pictured in the bottom row of boxes there. And we hypothesize that this collectively comes together and intersects to ultimately impact healthcare utilization, access, and outcomes. So we today are going to talk about Project 3, which is a qualitative analysis of the experiences and health needs of LGBTQIA+ people with CF. So what we did when we started this project, the first aim involved concept mapping. And concept mapping is pictured here, and you can kind of see the flow, and I'll walk you through it here. So brainstorming was the first stage. People were able to anonymously respond on an online platform called Group Wisdom to this prompt: things that people should know about the experiences of LGBTQIA+ people with CF are. And then from there, we took all of their responses, and the research team met with the Pride CF Community Partner Group to reduce those statements and get them ready for the next phase, which was sorting and rating. And here, the same participants who submitted statements in brainstorming got the opportunity to sort those statements into groups that made sense to them, and then also rate those statements relative to how important they felt they were or how much they agreed with them. We took that data, and then we used Group Wisdom to generate an initial interpretation and analysis. We took that initial interpretation and analysis back to our participants in our focus group review, and we gave them an opportunity to react to it, an opportunity to critique it, an opportunity to offer revisions. From there, the research team incorporated that focus group feedback into our final iteration of our analysis so that we were able to then come here and present it, disseminate it to all of you today. The reason I bring up concept mapping and to kind of frame for where we're going from here, our team felt that during the brainstorming phase, some of what was offered was not fully captured within the context of concept mapping. So a lot of individuals shared their stories with us, and there's a lot of context to those stories that weren't easily simplified and reduced to a statement that could be rated and sorted. So we had a subset of data. We had 22 individuals who were LGBTQIA+ with CF, and they offered us these narratives, and we were like, well, what do we do with these narratives? And essentially, the answer that we came up with was to do a separate qualitative analysis. So that's what I'm going to talk to you all about today. As far as missed opportunities, I didn't always look the way that I look now, and I presented much more femininely when I was younger, and sort of flew under the radar as far as my CF care team. And in the process of coming out to my family, sort of involuntarily, it made home life really, really terrible. And it complicated things with my health. So it took a breaking point for me to come out to my team, but it was me having to break that wall down and not them sort of opening things up and making me feel safe. And the result of a breakdown. This is just one narrative that our participants offered us that we felt the need to do an additional analysis. And I'm offering you the entirety of this narrative here today because I think it really succinctly communicates a lot of the themes that I'm going to elaborate on as we move forward. So like I said, this is a subset of data, and it was offered to us by the 22 LGBTQIA+ people with CF who entrusted us with their stories. Of these 22, 13 were gender diverse. What they offered us were 30 narrative statements. So during that brainstorming phase that I mentioned, they gave us 20 statements that were stories, essentially, not just statements. And then in the focus group review, they also offered an additional 10, which gave us 10 narrative statements or stories similar to what I just showed to you. From there, we did reflexive thematic analysis, which is a qualitative analysis technique that essentially systematically reduces that data from quotes to themes. You code the data. We ended up with a code book of 38 codes. We had 2 coders. We adjudicated to full agreement. And from there, we were able to generate themes. We ended up with 3 themes and 10 sub-themes. Here's a thematic map to kind of orient you to where we ended up. So there are 3 themes, which are healthcare challenges, equal importance, and social challenges. And then the 10 sub-themes that I mentioned are anchored to each theme that they come from. And I'm going to delve into those a little bit more here and give you all some context and offer some quotes about what goes into each one of these themes. So for healthcare challenges, participants shared mixed experiences related to sexual and reproductive health, as well as conflicts between treatments required for their CF and interventions that aided in gender affirmation. So within healthcare challenges, that first theme, our first sub-theme is sexual health. I'm going to read some quotes to you now. No one has ever asked me how I have sex or if I have ever had sexual pleasure. So for me, it wasn't until my adult CF team that anyone discussed sexual orientation or identity or anything with me. I mean, it was on their file that I was born intersex, so there was no hiding it or anything. It was known. The next sub-theme within healthcare challenges is fertility. People sometimes falsely assume that being infertile due to CF will be a barrier in my life. The reason I won't have biological children with my partner is because of my sexuality, not my CF, and that's okay with me. Our next sub-theme within healthcare challenges is missed opportunities. It gives off the impression that if they don't ask the question, it is not something worth talking about. And then our final sub-theme within healthcare challenges was CF treatments. I remember using the vest and how it made my chest bigger. I always would battle internally wearing it and complying with treatments. Our next theme was social challenges. Participants described the impacts of symbols of support, labels they identified with or that were applied to them, and the ways having CF impacted their ability to explore their identities. Within the theme of social challenges, the first sub-theme I'm going to talk to you all about is support. The symbols unless it's someone who's authentic, involved in the community, just trying to show acceptance, it doesn't show safety to me. When I travel for research, I see pins and rainbow lanyards and stuff like that worn by the research teams, and that actually does signal safety to me. The next sub-theme within social challenges is labeling. And I think that I'm pretty immediately labeled, and it's a big part of my life, just because of how I look and how I'm labeled by others, I think, too. The next sub-theme within social challenges is internalizing. For me, I used to think that surviving CF was more important than all other parts of my life. I was diagnosed with severe CF growing up, so I received my double lung transplant before my 21st birthday. And it wasn't really about exploring your identity or getting to know yourself. It was, can you survive the next day? Our third and final theme is equal importance. In this theme, participants who sought gender-affirming care shared the complex balancing required to receive the care, with many stressing that care for both CF and gender affirmation were important. Within the theme of equal importance, our first sub-theme is dual stress. My CF limits my ability to medically transition. It's so much harder to pursue when I have to work and take care of CF. There's so little energy left. I wasn't honest with my care team or my parents about the length of time that I would bind my chest for, which constricts how deeply you breathe, for a fear of that not being taken as seriously as CF. And obviously, I understand why, but I think at that time I was a teen and it felt like my gender was only important to me, or what made me feel comfortable was only important to me, and it was a battle for each thing. The second sub-theme within equal importance is deserving. Survivor's guilt is really hard when people with CF have friends who die. And as a trans person, it made me think I should be happy just to be alive at all, and that feeling at home in my body was too much to ask for. It took many years to realize my transness needed treatment, and also that I deserved this treatment. I used to think that surviving CF was more important than all other parts of my life, even my identity. Eventually, I had to make room for both. And our final sub-theme within equal importance is dual benefit. Getting hormone treatment and top surgery for my gender transition hugely benefited my health in unexpected ways. Some of my symptoms of CF improved directly, my outlook on life was brighter, and I felt motivated to keep living and fighting. This is the first study to elevate the experiences of LGBTQIA+ people with CF. This study highlights the healthcare and social challenges faced by this population, while also emphasizing the equal importance of these identities and the need for CF care and gender-affirming care to meet those needs. This is a launching point for the development of educational interventions that are needed to ensure CF care teams are accepting, affirming spaces for all. And because this is in action, our future directions are important to touch on, because you might be asking yourself, what are we doing with all of these themes? We're using them to inform the next steps of everything we're doing within Pride CF. So we're taking all of these stories and the themes we were able to generate from them, and we're using them to inform, one, the next step of Project 3. So we're developing an interview guide, and we're using these stories to shape the interview guide that we're developing for the next aim within Project 3. We're also using these stories to inform the outcomes of interest we specifically explore and the analyses we explore within Project 1. And then beyond that, we're also using this to inform training and education that Pride CF is able to develop and disseminate long-term. Pictured here is the full Pride CF team. I am incredibly honored to be a part of it, to work alongside these insightful, dedicated researchers. It's a blessing. And I also wanted to mention here that Pride CF is formally partnered with the Pride Study, which is the first national long-term health study of LGBTQIA+ individuals. Thank you so much for your time. I also want to thank each and every one of the LGBTQIA+ individuals with CF who entrusted us with their stories to share them. If you're interested in learning more about Pride CF, you can scan that QR code to sign up for our quarterly newsletter. We also have lanyards up here. I'm wearing one too with the QR code. We're really looking to build a network and to just get the conversation started. So thank you all.
So there's two ways to ask questions. Thank you, Rachel, so much for that fantastic talk and really elevating such and sharing such powerful narratives with us all. Mics are open, or you can use the app to have questions. We'll open it to the floor. Thank you.
Over here first.
Hello. Hi.
Hello.
Terry Laguna, Seattle Children's Hospital. Thank you very much for summarizing all this really important information. I basically have two questions. So one, did any of the LGBTQIA people with CF talk about the environment or the state in which they live and how that might be impacting their mental health, their access to gender-affirming care, and their CF care? I'm just curious if that came up. And then the second, I guess, question or comment is more, what take-home messages do you want people in this audience to hear from you today? I know this is a work in progress, and there will be lots of more things coming out of this, but what do you want this audience to actually leave here with after hearing all of this amazing information?
Thank you so much for those questions. I'll start with the first one. So the answer is yes, relative to safe environments, what is a safe environment, mental health, all of that did come up within that brainstorming portion of the study that I mentioned. And those statements that I'll elaborate on in another presentation later down the line were ones that made it onto sorting and rating. So yes, that context was captured and communicated by all the LGBTQIA plus individuals with CF that were in the study. Two, what do I want everyone to walk away from? I mean, honestly, what we learned from the individuals that we spoke with is it's a matter of making room for both parts of their identity when they're in front of you, right? So from a provider standpoint, making room for the whole person that's in front of you and making sure that you're meeting all of their healthcare needs is huge. So creating, as I mentioned, the accepting, affirming space for them to feel comfortable to show their whole self to you so that you can meet those care needs is what needs to be done. And that's gonna look different for everyone, but I think ultimately it's being willing to open yourself up and have that conversation and meet your patients where they're at.
Well said. Thank you.
Thank you so much. We're going to go over to this microphone over here.
Hi, Susanna McCauley. I work at Lurie Children's Hospital with John Paulus, so I'm somewhat familiar with this project. First, I just wanted to thank you and to recognize what a very strong community-engaged approach was taken here, where the participants were really part of formulating what your outcomes were for Project One. And also for this very deep, complex qualitative analysis, which, you know, many of us in the room do quantitative research primarily. It is so, there is so much science and art behind it that I think can be underappreciated in meetings like this. So I have also two questions. As a pediatric CF provider who has guided LGBTQIA and particularly transgender children in this process, did you get information on what helps or doesn't help kids who have identified as non-binary, transgender, with parents who are anywhere between completely unfamiliar and not understanding to actively fighting their own child's identity? So that's a very complex question. But I just wondered, I saw a lot that implied that, but I wondered if there was anything thematically that could help us start thinking about how we best do this.
So I know you said you have two questions. Do you want me to answer that one first?
Yes, and the moderators are free to cut me off too, because I'm long-winded and this is well recognized. So you can just answer that one because I can follow up separately.
Okay. No, thank you so much. No, that's a great question. Within the context of this analysis, we did not capture what you were asking about relative to youth and relative to their identity and their disclosure and their coming out to their families and their level of outness and their family's acceptance. And that was captured within brainstorming. And the way that was captured within brainstorming, statements were offered by our participants. One of them was to the effect that it was make sure you have conversations with youth without their parents present. And also make sure you're checking in with your younger patients to see who they are out to and who they're comfortable with you communicating that information to, even if that also means like who it's being disseminated to on their care team, if that can all be, I would say controlled, just so they know, right? And so that they're aware of what's happening. And it's really just kind of what you spoke about, like how we were constantly going back to the community and kind of creating a dialogue and that conversation. That's essentially what we're saying here, right? And that's what our participants were saying, is it's like, check in with us. Let's like walk through this together. And I think to that point, any opportunity you can make to connect with your younger patients when their parents aren't present, or even when their parents are present, without outing them is huge, and is a great launching point.
Thank you very much. I'll hold the other one because.
We have a question online we're going to take quickly first. So for the LGBTQ plus presentation, any differences between younger and older participants on the themes?
So we did not explore that. We did not differentiate for the sake of this analysis. We will be able to explore that within the concept mapping, the statements that were offered. We can look at an age comparison to kind of see like the difference generationally, to see what experiences were offered and how they rated and sorted those statements. But that's a really great idea.
I'll be quick. Greg Sawicki at Boston Children's Hospital. Rachel, thanks for presenting part of our work. And I think, as you said, this is the beginning of a big set of projects. To get to Terry's question about asking about state level policies, that's definitely something we're interested in thinking about. And what we need for all these questions, and to asking about Susanna's questions about what we can do and how we can help in terms of pediatricians and adult care providers and think about this, we want to assemble a larger cohort. And so I'm just sort of putting a plug right now that we are now able to, and we will start recruitment nationally for a larger cohort study that will be a mixed method study, including surveys over a regular period of time, as well as interviews. And so we're going to need everybody in this room to help us get the word out about getting people to sign up for the study. This is a completely decentralized approach. We're partnering with the Pride study nationally. We recognize the privacy and concerns that people may have about talking with their care teams about some of these topics, but we will allow for these are all surveys that can happen at home in a separate place, and we're going to also be putting this out on social media and through community voice. So if people aren't out to their care teams, they will still have an opportunity to provide their information. And once we assemble this cohort, and we estimate that we're going to find 300 to 500 individuals across the U.S., we'll then have a much richer set of data by which we can talk about regional differences, state level differences, approaches. And then one more thing, we did a provider survey, and so there is a poster at this conference that Tracy Kazmierski is presenting, looking at what providers are saying are their discomforts and comforts around caring for the LGBTQ population. And it's really insightful and eye-opening, and I encourage you to see that later in the meeting.
I'm sorry we're at time for questions, so yeah. Thank you, Rachel.
Thank you. Okay, next it is my pleasure to introduce Beth Lavin. Thank you, Theda. She is the Clinical Trial Matchmaking Program Manager at Emily's Entourage. And in case you are not familiar yet, Emily's Entourage is an organization that speeds life-saving research and drug development for individuals in the final 10% of cystic fibrosis who do not benefit from currently available mutation-targeted therapies. Please welcome Beth.
Thank you so much. I'm so grateful to be here to talk about Emily's Entourage, our Clinical Trial Connect patient database, and our clinical trial matchmaking service. EE's clinical trial matchmaking program is guided by our clinical research review committee, many of whom contributed to our abstract and who are here today. Thank you so much. EE's Clinical Trial Connect is supported by Genentech, Gilead Sciences, and Vertex Pharmaceuticals. Emily's Entourage is an innovative 501c3 foundation that accelerates research and for new treatments and a cure for people living with CF who are genetically ineligible or do not benefit from existing CFTR modulator therapies. Since its founding in 2011, EE has awarded millions of dollars in research grants and led worldwide efforts to drive high-impact research and drug development. Through EE's venture philanthropy initiative, EE launched and spun off gene therapy company Spirovant, which was acquired and is now in clinical trial phase. EE also organizes conferences and symposia to bring together world-class scientific leaders from the CF community and from outside the CF community as well. EE's work is hyper-focused on the final 10% of the CF population. And I'm using that term today, 10%, to represent those who do not respond to currently available modulators. I recognize this is based on US estimations and that ineligibility for modulators outside of the US is much higher. EE's clinical development efforts center around our CF Clinical Trial Connect, formerly known as our patient registry, and our clinical trial matchmaking program, which you will hear about in great detail. EE is guided by research priorities to fast-track treatments for people with CF in the 10% and to support buying time initiatives. This includes antimicrobial research for which people in our Clinical Trial Connect database might be eligible. Formerly known as EE's patient registry, our CF Clinical Trial Connect is a global direct-to-consumer database of people with CF who do not benefit from CFTR modulators. People with CF opt in to contribute their data to our CTC database. EE works with sponsors to share clinical trial opportunities and communications with registrants based on the data in the CTC. This combination of people with CF joining the database and of EE connecting registrants with trial opportunities helps to accelerate development of therapies with targeted and effective outreach. It also empowers people with CF to be part of the clinical development process by providing direct information and access. Any individuals with CF who do not benefit from currently available modulators are invited to join the CTC database. That includes those with genetically ineligible mutations, including nonsense mutations, and those who do not benefit due to suboptimal response or side effects. The database is open to people of all ages, including adults with CF, as well as anyone under the age of 18 who can be registered by their legally authorized guardian or loved one. And it's also open to people all around the world. We designed an intentionally simple database. It represents the information that we need immediately to be able to communicate opportunities with our patient population. We're constantly reassessing our needs for other data that may include in the future ethnicity, gender identity, et cetera. Right now, we collect, in addition to contact information, mutation and microbiology, as well as transplant and modulator status and willingness to travel for a trial. We are not seeking to recreate existing systems within the care center model or to collect data that is a snapshot in time. The privacy of this data is of critical importance to EE. EE does not share personal or individual registry data with companies or researchers. We only share anonymized aggregated data, and we follow privacy laws and regulations, making our database US and GDPR compliant. Our easily accessible and low barrier to entry CTC database can be found at emilysentourage.org/CTC. As of yesterday, EE's CTC database has 617 registrants. I think as of this morning, it was already up to 620. So we're growing, which is great. 56% are adults, and our database represents 49 countries across the world. 60% of registrants are in the United States, and the largest non-US populations include Australia, Canada, Israel, Ireland, Spain, and the United Kingdom. Our patient population ranges from newborn to 82 years old. We have more than 290 unique mutations across our database, and that's self-reported data. I've listed here the top 10 most prevalent mutations. It's worth noting that our CTC historically has served people with nonsense mutations, so our data mostly reflects this for now. But we just recently changed our outreach and messaging to be inclusive of anyone who does not respond to modulators, so we will continue to expand on that work. So how does EE's CF Clinical Trial Connect help to speed recruitment for the 10%? Our approach is rooted in EE's belief that people with CF are the drivers of their own health and should be equipped with information and opportunities to make their own choices about clinical research and care. EE's work is targeted, directly reaching and focused on the 10%. And this is a patient community that we have served since day one. We're deeply embedded in this community and are an authentic voice when we reach out to them. EE's CF Clinical Trial Connect seeks to accelerate clinical trial recruitment by making it targeted to people with CF who do not benefit from modulators. We connect people with CF from across the globe with relevant clinical trials through our clinical trial matchmaking program. When possible, we also help inform site location selection using our CTC data. Our Clinical Trial Connect promotes diversity and representation in trial recruitment. In the spirit of inclusivity, our focus has been more on the diversity of CFTR variants, but we know that non-white, historically marginalized populations are disproportionately prevalent among the final 10% that doesn't benefit from modulators. The CTC continues to iterate and adapt, so while we have focused on mutation diversity so far, we are actively considering other ways to include additional types of diversity in the future. Our program also offers hope and a sense of inclusion, allowing individuals that do not benefit from modulators to actively participate in the community's progress and be part of the solution. As we've seen in our survey data, this community has felt despair, they felt scared and left behind. Our Clinical Trial Connect offers them action and belonging. We want a big funnel of people who may be able to participate in studies. So we want the information to reach them as soon as possible, and we never want to act as gatekeepers. We identify registrants to receive trial communications based on criteria, but we also list inclusion-exclusion criteria in patient-facing communications so they can self-evaluate as well. Our clinical trial matchmaking program starts with the intake process. EE's Clinical Research Review Committee, or CRRC, is made up of CF clinicians, researchers, and community members, and they vet applications from sponsors. We encourage that all companies go through the TDN, so our committee is really looking at the best fit for EE and the best use for our CTC data. After approval, EE contracts with the sponsor for recruitment and outreach services. Companies pay a direct fee to EE for outreach, a project fee, so it's not based on the number of contacts we reach, referrals, or any specific outcomes. And EE's direct outreach complements existing recruitment approaches via CF Care Centers, CFF Trial Finder, clinicaltrials.gov, and others. Once the contract is in place, EE connects people from our CTC database to relevant clinical trials. This is a high-touch handoff designed to get information to the patient population and to help usher them through. It also seeks to minimize drop-off. We don't do anything clinical. We identify registrants who may be eligible for the trial based on the inclusion-exclusion criteria that we are provided that overlaps with the information in our CTC database. We then customize patient-facing information, which the sponsor approves and gets IRB approval. EE then reaches out to the people from its database and usually send a follow-up email a few weeks later as well. And then people with CF respond directly to us if they're interested in learning more about the study. At that time, we're able to help them identify the most appropriate trial site for them or answer any basic questions about the study. And then we get their consent to share their information with the site coordinator. At that point, the site takes over and works directly with the registrant to screen them for eligibility. EE tracks outreach, response, and referral metrics throughout this process, and we also ask sites to track referral data so that we can ultimately measure the success of this matchmaking program. Looking at the different components of our program, we analyzed our data since 2020. We have seen organic, steady growth of about 12.8% year over year, going from 350 people in 2020 to 620 plus today. The split is about, again, 60% in the US and 40% international. And we have recently focused on intentional outreach, especially with international partners, in the last few weeks as we reintroduced and rebranded our patient registry as the Clinical Trial Connect. As we look to the future, we realize that in order to fill studies and speed recruitment, we're going to need more people and greater representation beyond the US. Our clinical trial matchmaking program has vetted 11 applications since 2020, and we've supported 5 trials. We have sent 715 outreach emails and follow-up emails as well. We've received 57 responses from people with CF interested in learning more, and made 33 referrals to 20 sites across the US. Here are some direct quotes from various stakeholders who have benefited from and participated in EE's Clinical Trial Connect and Clinical Trial Matchmaking program. So from a clinical research manager at Boston Children's, he said they were blown away by the effect that EE had on initial recruitment for the trial. And from a sponsor who has utilized our recruitment services, they were proud to participate to provide information and access to clinical trials solely focused on this high unmet need population. From a person with CF who is a member of our CTC, she heard about this study through EE probably 3 months before they heard about it anywhere else, and said that Emily's entourage makes them feel less alone in this fight and empowers them as a patient to get connected to research opportunities. In conclusion, EE is proud of the growth in our CTC database to date and of its reach in representing so many countries and patient populations worldwide. We are investing in national and international partnerships and working with care centers and patient advocacy organizations to try to bring more attention and more people to the CTC patient database. We have validated the need for this tool as an effective strategy and complement to existing systems for recruitment. Going forward, this is a shameless plug. If this work rings true to you, we need you to refer your patients, refer your loved ones, and help us spread the word. On the NACFC app, you should have access to a handout that can directly link you to more information about our CTC. And I also have my colleague Miriam here with me today, who has flyers as well as these excellent 100% or bust buttons that we would be happy to share with everyone. If you're a company, we would love to explore working with you, so please come find me after. With more people in the CTC database, we can enroll trials and speed breakthroughs even faster. And I know that is a shared goal of everyone in this room today and everyone here at this conference. So with that, I will thank you and happy to answer any questions.
Thank you so much. We have some questions online as well as at the microphones. We'll take the microphone first. That would be you.
Okay, thank you. Hi, my name is Rebecca Cowell, and I am the CF pediatric nurse at Columbia Presbyterian in New York City. Thank you so much for the awesome work that you're doing. I just had 2 questions for you, and they're directly related to those members of our pediatric CF patient population who are in that final 10%. First of all, do you have interpreter services, and or is there an ability to translate your website into Spanish?
Yes, great question. We do, and we are working on that. I am not sure if it's live yet, but if not, it will be live soon. Okay, it is live. Someone's confirming. Thank you very much. And I know we have Spanish and are working on several other languages as well. And that will both be the landing page of our website as well as the consents and information to enter the registry.
Okay, and how about Spanish language handouts?
Miriam, do we have Spanish language handouts? Not yet, but if you connect with Miriam, she can happily connect you with those resources.
Okay, thank you.
Yes,
My
thank
second question is, does Emily's Entourage offer financial assistance for study-related travel?
So that is not a program of Emily's Entourage, but we, during our vetting process, are able to give feedback back to the company, to the sponsors about their trial design, and we often encourage that. When we're developing the language that we will then send out to our patient community, we always ask them their policies around compensation and include that language as well. So that's something that we're actively pushing for, but provided by the sponsors, not by Emily's Entourage.
Got it. Thank you so much.
Thank you.
Hi, I'm Silvia Cardenas from Cleveland Clinic. I have a couple of questions, and perhaps some of this has been mentioned and I missed it. But so one is if you have any information on the registry that you have as far as demographics, ancestry, ethnicity, what's the predominant group, if you have information on that.
So right now, our information is fairly limited. We have location of where people are, but we haven't added that level of detail yet. And I'm happy to add that to our considerations. That's helpful. Thank you.
Okay. And the other question that I have is if the access to the registry or for people to be able to sign up for the registry, do they have to belong to a CF center or CF registry? And if this is accessible to countries where there is no formal CF registry?
Yes, that's a great question. Thank you. No, they do not have to belong to a CF care center. The registry is open to all, and that's part of our mission, is to make it easily accessible. It probably takes 5 minutes to sign up, so hopefully it's very easy for patient populations worldwide to enter their information, and then if there are studies that become available in their area, we will let them know.
Thank you.
Thank you.
We have a question online. So the question is, can patients with CRMS or CF-related disorder without qualifying ETI mutations participate in these trials despite not having a full CF diagnosis?
Great question. I am not a clinical researcher, so there might have been some terms in there that I don't know, but we encourage anybody to join, and as I said earlier, we try to not be the gatekeeper of information. We really want to push out information to the patient community. So they may be marked as eligible for a certain study based on their age and location, and then they would get all the inclusion/exclusion criteria from the study sponsor, and they can make their own evaluation along with their care team about whether or not they may be eligible. So we would encourage those types of people to still join, put their name into the database, and hopefully we will have something for them.
Thank you. We do have another online question. They just keep coming in. This is great.
I'm happy to talk to anyone else after, and we also have a poster session tomorrow, 434, I think.
So one of the questions is, what are some of the recruitment strategies used to engage patients and families?
So for the most part, we are emailing direct information to the people in our registry. We also have a homepage on our registry, which is available on the portal to anyone who's logged into our registry, or to our database, sorry. So anybody who is a member will see a homepage with all of our available studies that we're recruiting for. So while you may be outside of the US, you could log in and see the studies that we're working on in the US and reach out to us that way in case you're interested in traveling. And then we also partner with sponsors, to support their outreach efforts as well. We talk about it in all of our work that we do, like the work here, and just continue to try to help spread the word as best possible.
All right, another question from online. Do you have any tips for approaching patients in the 10% that feel burned out by clinical trials they have participated in that were not directly helpful to them, causing extreme disappointment and further isolation?
Yeah, that's a great question, and that's something we hear a lot from this patient population. Emily's Entourage is the only organization that is hyper-focused on research specifically for this population. So I would encourage those people to join and to learn about the work that we're doing, and hopefully we will have something for them. We have heard from a lot of the providers that we work with that it can be really frustrating to not have anything to offer your patients in the 10%. And so being able to have a flyer or information about our Clinical Trial Connect may be something that is a direct action that they can walk out of their next appointment feeling like hopeful and I have something to do and a community to belong. And then just continuing all of the great education that the partners in this room and at this conference do to get people to understand all that goes into participating in a study. We're very hopeful. There's a lot of activity in the pipeline right now, and so this is a great time to be part of the CTC, and hopefully we can make some real improvement here for this patient population.
All right, for our last question that's from online, it may take you more than the minute and a half we have left, but let's see what we can do.
Okay.
So for those who have been referred, do you know how many were screened and enrolled in trials and what type of trials they were connected to? And then the second part of the question is, how do you manage international referrals?
Okay. On the first question about enrollment data, we are pretty hands tied by sponsors and sites that we work with to actually report back out enrollment data. That's something that we're constantly trying to push for and work on because we know how important it is. So I don't have and can't share a total number there. Sometimes sponsors and sites will report back to us the number of successful referrals that led to enrollments, and sometimes they won't. So it's somewhat incomplete data. And as far as international, we just piloted our first outreach in Australia just last month, actually. So we're still learning and growing in that area, and really relying on a lot of the great work Miriam has been doing to build up our international partnerships so that we have patient advocacy organizations on the ground in the countries where we're trying to work that can help us guide the process and help us access their patient populations as well.
Thank you so much.
Thank you.
All right. Thank you so much, Beth. I'm going to introduce Dr. Frida Leo. She's a pediatric psychologist at Seattle Children's CF Center and associate professor of psychiatry and behavioral sciences at the University of Washington School of Medicine.
This one fit. All right, good morning. So today I am here to share with you an implicit bias training that my colleagues and I designed for the CF care team members that was delivered here at NACFC last year in 2023. And I hope to share with you some of the content as well as our evaluation data. Okay, so these are my disclosures. The CF Foundation supports research grants for me, travel support, and they also provided an honorarium for the delivery of that particular workshop last year. And I also received funding from the National Institute of Mental Health in terms of research grants that supported the development of the precursor versions of this training. Okay, we have an ambitious agenda today. I'm going to provide some background, cover workshop content, get to the evaluation data, and hopefully wrap up with conclusion and future directions. So I'm sure most of you in this room are familiar with at least some of these statistics in terms of the well-documented, long-standing inequities in CF care. So I won't belabor the point by going through each of these, but I think it suffices to say that as you look at these disparities, we can recognize that these health inequities in CF care ranges from birth to death and covers the entire lifespan and just about every significant indicator of disease progression and severity. And that these types of disparities or health inequities have been found not only along lines of race and ethnicity, but also along the lines of socioeconomic status, as well as sexual and gender identity. And one common denominator that has been identified in the broader health equity literature for these types of inequities is healthcare professionals' implicit bias. And before I go on any further, just to ensure that we are all on the same page, when I say implicit bias, I am talking about attitudes, stereotypes, beliefs that affect our judgment and behavior toward an identifiable social group that operates automatically and beyond our volitional control. Notice that I did not say unconscious. right? Modern implicit bias research tells us that, in fact, most of us are able to tap into a sense of awareness of what that implicit bias feels like. And this awareness is important because if we are going to intervene and teach people how to mitigate the impact of their implicit biases, we have to be able to become aware. So you might wonder, what are the pathways that leads from healthcare providers' implicit bias to downstream health inequities? And essentially, there are three pathways. Healthcare provider implicit bias can affect our judgment and decision-making about patient care that then leads to negative outcomes. And this could be an example of a PCP telling a Black family that they can ignore their newborn screen because they're not white, right? A second pathway is that healthcare professional implicit bias can erode the trust and interrupt communication between patient and providers that then leads to poor patient engagement and adherence to the healthcare professional's recommendations for care and then leading to disparate outcomes. This makes intuitive sense, right? If you don't trust your healthcare provider, you're not going to follow their recommendations. And then finally, as healthcare professionals engage in policy and decision-making about healthcare policy, we then have inequities baked into our system of care. And so recognizing, in case you're wondering how big this problem is, implicit bias has been well documented among health professionals across a multitude of professions and disciplines. And if we begin with physicians, I won't read all the categories, but as you can see, many of the specialties that are often represented on our CF care teams, studies have shown that physicians evidence implicit bias within those specialties. And just to be sure, I did find a 2023 study that looked specifically at implicit biases among pediatric pulmonologists. And beyond physicians, we have implicit bias well documented among nurses, pharmacists, dietitians, physiotherapists, occupational therapists, genetic counselors, and mental health providers of many stripes. Did I miss anybody in the room? Right. Oh, respiratory therapists, I see you. You have been included in these implicit bias studies, but often in mixed samples of healthcare providers. So I didn't find a study that was only about respiratory therapists, hence I didn't list you all on the slide. So enter implicit bias workshop for the CF care team member. Just a little bit about the training development. So there's a well-established evidence base for implicit bias interventions, mostly from the social psychology tradition. And originally there was a workshop that was developed by Dr. Jeff Stone at the University of Washington for internal medicine residents, which and this intervention has since been tested in a NIH-funded trial and shown to be efficacious in reducing providers' implicit bias. And so I collaborated with Dr. Jeff Stone as someone who is interested in developing scalable psychosocial interventions specifically for healthcare providers. I had the idea that if I could teach healthcare providers to do all kinds of complicated interventions with their patients, why can't I train them to manage their implicit bias with a highly scalable digital training? And so in partnering with Dr. Stone, among other implicit bias intervention specialists, we iteratively developed, using human-centered design principles, a digital training that is known as Virtual Implicit Bias Reduction and Neutralization Training, or Vibrant. And Vibrant is currently in its own NIH-funded pilot feasibility trial. And once I had this intervention, by popular demand, I started providing this digital intervention live. And so this is my full circle moment, right? I took someone's live intervention, turned it into a digital intervention, and then I started providing them live again because people really wanted to be in person. And once I started doing that at local and national conferences, I really wanted to bring this work to our CF community. So I adapted that material into a 3-hour interactive workshop for the CF care team context, and with the support of the Cystic Fibrosis Foundation, as well as the our psychosocial collaborative meeting, we delivered that workshop in that context last year at NACFC. So specifically, the workshop has just a little bit about the format. I really tried to keep the didactic information or the portion to a minimum of about 45 minutes, and then it includes live demos, and most of it is really engaging learners in these role plays or real plays. Role plays are when you're pretending to be someone else, real plays when you're practicing as yourself, right? And these role plays or real plays are important in the development and strengthening of implicit bias mitigation skills. If we expect people to change behavior, we have to give them opportunities to practice those behaviors. says the behavior psychologist. Okay, so here's the workshop content. We provided an overview of health inequities in CF care to really make the case of why implicit bias training is important. And then we dive into bias literacy training by providing an understanding of the nature of implicit bias, particularly discussing its social evolutionary advantages, as well as the nature of being automatic, fast, but error-prone and ubiquitous. And the efforts here are really to normalize and destigmatize bias so that all of us get more comfortable with the idea that, in fact, we all have biases, and that the task here is not to avoid or to rid of ourselves of biases, but really to get comfortable with them so that we can manage them and their downstream impact. For those of you who might be familiar with the implicit association test, which typically is done as a computerized assessment that looks at the strength of your relative associations in terms of attributes and groups of people. So this may be standardized with white and good, black and bad versus vice versa. And this is typically done, like I said, on a computer. But in this training, I provide a sort of an analog version of a live demo. And I'd hope that we'd be able to demonstrate that today, but we really don't have time, unfortunately. But the idea here is to allow people an opportunity to experience in community just what it feels like to grapple with your biases in the moment, to give folks a sense of that sensation of becoming aware of your implicit bias. And this is especially important because it addresses the phenomena of the bias blind spot. And this is the idea where folks are comfortable and aware that, yes, biases exist in the world and it affects health inequities, but it doesn't exist here in our own mind, right? So this is really to bust that idea. No, it's in all of us. And then finally, we do a brief literature review on bias among healthcare professionals before we dive in and spend the rest of the 2 hours on the specific bias management strategies. In terms of the bias management strategies offered during the training, we talked about preparatory and foundational skills, including increasing bias awareness with the practice of mindfulness and empathic listening. So I emphasize that these are important preparatory foundational skills, meaning that they are necessary but not sufficient. The piece that is crucial is implementing these additional in-the-moment bias management strategies, which has the strongest evidence-based support from social psychology. And so the three that we focus on are seeking commonality, perspective gaining, and counter-stereotyping. And I'm going to try to give you a really quick overview of what these strategies are so that you can walk away from this feeling like, okay, I know at least some things about what I could do to manage my biases. Because I think one of the weaknesses of so many implicit bias trainings that are now proliferating, and there's really been a rapid proliferation, especially since 2020, is that much of the training deviates from the evidence base and does not give folks enough tangible skills on what we can do in the moment. Okay, so seeking commonality. Here, the goal of this strategy is to really decrease social distance or that sense of otherness when you're interacting with someone who does not share your primary social identities, and to increase that sense of like, oh, they're just like me because we have some things in common. And so here the idea is that we ask the healthcare professional to interview the patient for shared interests, activities, identities. So things like sports and teams that you both support, music and hobbies that you both like, shared educational backgrounds, locales that you've been to, family structure, traditions, etc. You can imagine that the variation here is rather endless. And this is actually fairly familiar of a practice, I think, for most people. For those of you who might be familiar with PEPS training, the Partnership Enhancement Program, this might be part of what you do with the small talk before the big talk, right? The only thing that's a little bit different about this for the provider is that it does require a little bit of self-disclosure if you're not used to that, right? In order to create that sense of we have something in common, you do have to share with the patient that like, oh, I too like this activity. Okay, and then we have perspective gaining. This one, again, might be familiar to folks. The idea here is to understand the experience of another by seeing through their lens. And you do this by using open-ended questions to ask about their experiences, thoughts, and feelings, because there's really no other way to truly get at someone's experience unless you ask about it. Right? So the encouragement here is find out what their experience is like. Now, this is not asking what would you do in their situation, Because when you ask, what would I do in that situation? You're bringing along all of your own privileges and experiences and history, as opposed to centering their experience. And this is why we don't call it perspective taking, but rather perspective gaining. Whew, I'm being warned about time. Okay, counter-stereotyping. This is by far, not by far, this is arguably the most powerful yet most difficult bias busting strategy. And the idea here is to intentionally gather evidence to refute salient stereotypes. So for example, if you're working with the stereotype that Latinx patients may be non-compliant, you need to find out about their compliance history. And that if you end up in a situation where you're actually finding stereotype confirming evidence, that is okay, because that piece of information is specific to that patient, to that family, right? The idea here is to not rely on the stereotype that you have about the patient walking in. Okay, quickly on to workshop evaluation data. We had about 40 attendees, and 31 of those attendees completed both pre and post-training evaluation. The group was fairly diverse, with about a third identifying as Hispanic and about 2/4 identifying as social workers, with an additional smattering of psychologists, mental health therapists, and those who identified in other roles. The training showed a significant improvement. Participants showed a significant improvement in their implicit bias knowledge on a 10-item multiple choice quiz, and that's a large effect size with a 13% increase in their score. They also showed a significant improvement in their willingness to acknowledge their personal bias using the acknowledgement of bias scale, and these are some examples of items that they responded to. And this is a moderate effect size. And then finally, we asked about their sense of feasibility and acceptability for the training, and in terms of their agreement or disagreement on these statements, like, I have gained new information and skills from this workshop was worth my time. And this was done on a scale of 1 to 5. And as you can see, these items were highly rated, as they all averaged above 4.5. And we also collected some qualitative feedback on an item where we asked them to identify the most important takeaway. 14 out of 24 free responses cited a specific strategy. So this was good news to me, that people really got the sense that, like, yes, there are strategies you can use, and these are the ones I'm taking with me. 6 people cited a general approach of being open and curious, and 3 cited specific knowledge gains, such as those about inequities in CF care. And then we just had a general open-ended questions of anything, other feedback that they wanted to give us. And in addition to just general praise, we had this lovely theme of people really liking the interactive exercises. And then the next most prevalent the next most prevalent theme is that this training really should be offered to all the disciplines. People really wanted to bring the training back to their team. So my conclusions is that evidence-based implicit bias training can improve bias knowledge and acknowledgement of one's own personal bias, and that there appears to be high acceptance, feasibility, and a particular demand and appetite for implicit bias training for CF care team members. So in terms of future directions, in collaboration with Dr. Theda Ong, as well as our colleague CJ Bathgate at National Jewish, we're actively pursuing funding to support the development and evaluation of a digital version of this training, in the hopes that we could test it and compare it against the live workshop.
Thank you so much. So we have about 7 minutes for questions, and we do have one online. Have you looked at the effect of implicit bias training when it is mandatory versus voluntary?
That's a very good question. I have not personally looked at this question, but there is data in the literature that suggests that when you mandate implicit bias training, you could have an iatrogenic effect, where people sort of get fighty about the process. But the good news is there is also evidence in the literature that suggests when you provide implicit bias training on an organizational level, you only need a certain percentage, like 20 to 30% of people getting trained for the training to have a system level benefit. So that tells me that it doesn't have to be mandatory. If we have enough volunteers, we'll do all right.
I have a question for you, Frida. Thank you for that great talk and sharing all this incredible work. What do you see as specific adaptations to the CF care team versus like a more general implicit bias training?
Oh, thank you for that question. So one of the things I failed to mention about the workshop, that it's much of the role plays and the real plays are case-based, so that people are working with cases that they would likely encounter in their CF care team or in their your general clinic visit. And so that is one part of the adaptation, is to really make those scenarios real world and to fit, how our typical multidisciplinary CF team visits might go. And the other piece is to recognize the teaming aspect of CF care, right? That we do work together as a team, and that the patient is having interactions with multiple people, and that they may be reacting to something that happened with someone else that you may be walking into and having to respond to.
Thanks for a really insightful presentation and all the work that you've put into this. You mentioned PEP as another example of communication training that's become more broadly available to the CF Care Center network. I'm wondering if you can comment on what your team's plans may be to try to spread this type of a training activity either throughout the CF Care network, outside of sort of just conferences or sort of once a year events. So are there plans to sort of think about that? Because I think the PEP model has been really, really great, and I would love to see this spread a little bit further.
Yeah, thank you for that. We do have some plans. I'm a bit hesitant to comment on those plans because they're currently unfunded wishes, right? But we've certainly, Theda and I have spent the last few months very painstakingly planning how we might be able to do this. And we really hope that if funded, we would like to begin a trial within the CF Learning Network first, and to see scalability and feasibility so that we really have a good sense of how to spread.
We have another question over here.
Hi, I appreciated the discussion and the presentation very much. I'm curious about how you measure the advantage of doing implicit bias training voluntarily on the patients. Like how do you look at or evaluate the impact on the patient in putting a voluntary program like this in place?
Yeah, thank you for that. From a research standpoint, getting patient outcomes is in fact the most difficult bar to reach. And as someone who is currently running a trial with a digital training, I will tell you just how difficult that is to recruit patients. This is not in the CF context. I do think that in the CF context, we have some advantages for doing that if we get to do this because of the attachment to the care team. And ideally what we should see, especially if we're seeing center level change, meaning you train the whole team and something about the training really shifts the environment and the culture of the team and the way they interact with patients. Ideally, we should see an improvement in patients' reported experiences with those care providers, especially among groups who are historically marginalized. Right? So again, in order to test that, we really need a sizable trial to see if we can spot some differences between teams, patients who are receiving care on teams who've gotten the training versus those who haven't yet.
I think that's it. Thank you so much.
All right. Moving along, I'd like to bring Dr. Brittany Truitt, who's a pediatric pulmonologist and assistant professor at Emory University and Children's Healthcare of Atlanta.
Hi everyone, my name is Brittany. First, I want to say thank you to the organizers for inviting me to speak today. I'm very excited to share our work with you. Today I'm going to be talking about quality improvement to improve timeliness of sweat chloride scheduling for infants in Georgia with an abnormal CF newborn screen. This is my presentation disclaimer. I have received clinical training grant support from the Cystic Fibrosis Foundation. Before I tell you more about this project, I want to start with a patient story that has kind of inspired me to get involved with this. This is a patient that I met during my fellowship training. At the time, she was a 3-month-old Hispanic female infant who had just been diagnosed with CF after she had an abnormal sweat chloride test. She had had an abnormal newborn screen with one CFTR variant, and her pediatrician had referred appropriately for sweat chloride testing. However, mom was only Spanish speaking and had a lot of difficulty actually scheduling this sweat test. It went as far as to mom showing up for the test and not having an appointment and being turned away. Because of all that, she didn't actually receive her diagnosis until 3 months of age, and she came to her first CF clinic visit at that time.
Just speak a little closer to the mic.
Oh, yes, sorry about that. She came to her first CF clinic visit at that time, and she had signs of malnutrition, failure to thrive, and persistent cough. She was immediately admitted to the hospital after that clinic visit, and you can see here by the chart, she had fallen far below on her growth chart, and her weight had not really increased even since her birth. This led to a long hospitalization where she received NG feeds And ultimately, this delay in diagnosis created a lot of medical mistrust from the family that we are still working through today. To give a little bit of background about our newborn screening algorithm, we are a two-tier screening state. So the first one is IRT values, where values greater than 55 go on to second-tier testing, which currently is a 39-variant CFTR panel. If there is 0 variants, that is a negative test. If there are 2 variants, that infant is referred directly to one of our CF centers, either in Atlanta or Augusta. If there is 1 variant detected, that child needs to go on to get a sweat chloride test, also either in Atlanta or Augusta, to help determine if they actually have CF or if they are a CF carrier. The recommendation from the CF Foundation is that babies with a positive newborn screen should have a sweat test performed by the age of 4 weeks to ensure that any health issues or changes can be found early and treated quickly. This applies to about 250 to 300 newborns in the state of Georgia who have an abnormal CF newborn screen with 1 mutation each year. We know from previous registry data that infants who are Black, American Indian, Alaska Native, Asian, or other races or Hispanic ethnicity often have a later diagnosis compared to white infants. With ongoing work that we're currently doing in the state of Georgia, we are also supporting this finding. And we have also found that in the majority of our infants with delayed diagnosis, that sweat chloride testing barriers was the biggest reason of why there was a delay. In the state of Georgia, we also serve a particularly diverse CF population, with about 10% of our population being Black and about 8% being Hispanic. With all of this information, we created a global aim between our center in Atlanta and our center in Augusta to increase the quality and equity of CF diagnosis. This led to the creation of a QI work group, which includes pulmonologists in both Atlanta and Augusta, a QI analyst, the lab director, multiple members of the sweat chloride lab, newborn screen follow-up coordinators, again, both in Atlanta and Augusta. This data was not something that we had on hand when I first started this project, so I went back to the year of 2022 to try to get an idea of what is our baseline currently from the time from birth to the time from sweat chloride test completion. We separated that by Atlanta and Augusta because knowing that the processes are different, we thought there might be different results between the two. Here we found that in Atlanta, our baseline for 2022 from birth to sweat chloride completion for those infants with 1 variant on their newborn screen was 45 days, while in Augusta, it was much lower at 28 days. You can also see that Augusta had a lot less variability overall in their averages throughout the year. To give you a little bit better idea of how our processes work, and I know this is small, you can also see it on my poster, number 747, but to give you a little background, when an infant has a newborn screen with 1 variant, that information is faxed to the CF center either in Atlanta or Augusta based on the infant's zip code. It is then the responsibility of the pediatrician to order a sweat test for that infant. In Augusta, if that pediatrician hasn't ordered a sweat test within 48 hours, they have a newborn screen coordinator who then follows up with the pediatrician directly and provides them another newborn screening packet and helps them kind of understand the importance of ordering that sweat test immediately. The newborn screen coordinator in Augusta also helps the family schedule that sweat test, and then the sweat test is completed. However, in Atlanta, when the pediatrician orders the sweat test, it is then the responsibility of the pediatrician to give the family a phone number to call to actually schedule the sweat test. It is then the responsibility of the family to call that number and either get through and talk to someone directly to schedule or leave a voicemail, which is then returned to then schedule the sweat test, and then it is completed. So you can see in Atlanta, there are a couple areas where things could fall through the cracks, and we are assuming that every pediatrician kind of knows how to operate and has that phone number to give the family. We're also assuming that the family then has a means to be able to call and schedule that appointment. With this information, we developed our SMART aim for the project, and our SMART aim in Atlanta was to reduce the time between birth and sweat tests from 45 days to less than 28 days for infants with an abnormal CF newborn screen who follow up in Atlanta. Our process measure would continue to be the number of days from birth to sweat test completion. Again, this would apply to all infants with an abnormal newborn screen with one CF mutation, meaning those that go on to have CF and those who go on to be labeled a carrier. We then developed our key driver analysis, and I'll go over our drivers here a little bit. We start at the level of the infant actually having, an infant at risk of CF actually having a positive newborn screen. Next, we need the pediatrician to understand the newborn screen results and their next steps. We need the pediatrician to then order the sweat test in a timely manner. We need the parent to call to actually schedule that sweat test, and then we need the lab staff to be involved in also scheduling. Using our drivers, we then developed interventions, which I'll go in a little bit more detail here on the next slide. Our first intervention, and in my opinion, one of our most impactful interventions and most relevant to today's session, was in December of 2022, where we were able to update the instructions on the voicemail, and more importantly, able to add a Spanish option to the phone line. So when parents called who were Spanish speaking, they were able to choose a Spanish option and better be able to utilize that service. We were also, over time, able to increase the real-time monitoring of the sweat line by lab staff, and so that it was more likely that when a family called, they would actually get a real person rather than a voicemail. For the third intervention, I was able to hold some sessions for education to the lab staff about the CFF recommendation and why we care to get this done in a timely fashion. And then finally, our intervention of December of last year was that we were able to add our children's healthcare requisition form to the newborn screen packet. This is where it's been really crucial that we're working with the newborn screen follow-up program to give more explicit instructions and include the sweat phone number and all the information that goes to the pediatricians. So I'm excited to tell you that after beginning our interventions, we have been able to see a shift in our average number of days from birth to sweat test. You can see here our interventions started in December of 2022 and have continued on throughout the current time. And we have been able to shift this down to 28 days is now our average time from birth to completed sweat test. And we have been able to kind of maintain that over the last few months. Augusta has been able to maintain also their average of 28 days from birth to sweat test completion, and Augusta has began to do interventions earlier this year and is working on improving the communication between the CF Center and surrounding pediatricians. I also want to share a little bit with you about our future interventions, one that we were just able to start this past month. This is an example of the letter that comes from the newborn screen follow-up program, and we were able to work with them to help adjust some of the language in there to better emphasize that infants of all races and ethnicities can have CF. So the first thing we wanted to add was in this top part here with the arrow in blue, where we added that sweat test should be done within 2 weeks, and this is so that hopefully the final results will fall within those first 4 weeks as recommended by CFF. And then at the bottom here, we added a little bit more specific language about cystic fibrosis, saying that CF can occur in infants of all races and ethnicities, and that infants of color are at a higher risk of delayed diagnosis. So we want the pediatricians to make sure they see this and keep this in mind when they're sending their referrals. This is the letter that's being sent in both Atlanta and Augusta, so we hope that it's going to have a positive impact in both places. So finally, in conclusion, Atlanta has been able to decrease the average time from birth to sweat test completion for infants with an abnormal CF newborn screen with one variant from 45 days to 28 days. Augusta continues to average 28 days and is implementing ways to improve communication on risk of CF to pediatricians. And finally, we want to ensure that future interventions will need to continue to emphasize approaches that lead to an equitable CF diagnosis for all children. Thank you to my whole QF team.
Thank you, Dr. Sherwitt.
Okay, we have a question online. From your experience reducing this barrier, what other barriers do you think patients with preferred language other than English experience in their CF care?
I think one of the biggest ones is the bias and misconception that that child would be less or unlikely to have CF. That's something we kind of hear mostly in our Black patients, but I think that would also apply to our Hispanic patients as well. And then I think just navigating the healthcare system overall without English being your first language is obviously a challenge that I can't even imagine. So we just want to make sure we keep that in mind with any future interventions as we work towards things like online scheduling and whatnot, that also has Spanish options for those families.
We have a queue over here, so we're going to go to this microphone first.
Hi, great talk, appreciate it. I noticed when you put up the map of Atlanta or of Georgia that your two centers are kind of in the north part of the state, and I was wondering if you noticed any trends in terms of travel for some of these families, and if there was, the folks that took longer lived further away, and if you were able to counter that in any way.
Yeah, I don't have that granular of data of exactly how far each patient was from their center or anything like that. I would expect that has a negative impact on their time for how long it takes to get their sweat test completed. More so, I have it in things I just heard from members of the sweat lab themselves, where they would receive calls from parents that are like, I have to travel 4 hours to get there, but my pediatrician said I probably don't need this test anyway, so I think I'm just going to cancel. And so, we hear things anecdotally like that, but I don't have the actual data for that question.
Thanks very much for an excellent presentation. Mark Chilvers from Vancouver, and congratulations for bringing down that from 45 to less than 28 days. That's a lot of work, I'm sure.
Yeah.
So one of the challenges we find in Vancouver is having the MRP, so when we're trying to contact them with the results of a positive newborn screening test. So what proportion of infants through newborn screening have a pediatrician?
That's a great question. I think that the newborn screen follow-up program would have a little bit more information on that. I think they do experience times where it's difficult for them to figure out who to contact when they just have this information from the birth hospital. So I don't have that exact number, but that I'm sure is related.
Yeah, because I think if you're going to ensure there's equity in terms of access to sweat testing, it's going to identify who's the missing population from that who don't have pediatricians or a primary care physician. So, thank you.
Thank you.
Thanks for showing us how rigorous QI science methodology really impacts outcomes and changes, through this process that we use. I have two questions. One is, how complicated was it to work with your state university, changing the language around the like, how did you lobby for that? How were you successful doing that? And two, did you satisfy your own person at all by ethnicity or language to see if there were differences? But based on that, I was thinking priority of policy to make them challenge for diagnosis. I'm wondering if
we are very fortunate that one of our newborn screen follow-up coordinators, her name is Angela. She was in the title of this talk as well. We're very fortunate that we have about monthly meetings with her where we're able to discuss some of these things, and that she is located physically on the Emory campus as well. So that helps a lot. I have many emails, and she responds very quickly, and so it's been wonderful working with her, and she's truly been so necessary for any of this work. The second part, I did not obtain that level of data for each patient. I was really just getting their date of birth and the date of sweat test, so it has not been stratified by that at this point. But I do think that would be very interesting. That would put a little bit more research angle on it than QI for sure, but I think that's something that'd be great to look at.
We've got 3.5 minutes and a lot of questions, so we're going to go over to the mic.
Thank you. Susanna McCauley, Chicago. That was a great presentation. I commend you on this work. I did wonder, with the primary care provider being the gatekeeper to a sweat test, and the sweat test seems to be a gatekeeper in most cases to the CF center. So particularly given the very high rate of preterm and small for gestational age babies born to Black women because of all the structural and medical racism that we have in our country, what is your protocol for the kid who has a positive test with one variant but is premature or small for gestational age, because the recommendation is if you can't get a sweat test or if it's QNS, you ought to have a clinical evaluation with a decision favoring treatment if there's uncertainty.
Yeah, I think that is a really challenging population, and some of those are definitely wrapped into these numbers, and I think contributes a lot of those ones that took a long time to diagnose, because often those babies are going to be still in the NICU. We get a lot of calls, honestly, from NICUs about what to do in this situation, and we always just go to CFTR sequencing. But even that takes, 2 to 3 weeks if you're lucky for it to come back. So I think we don't have the capacity for a pulmonologist to go physically evaluate, most of these infants. But I think that's part of the education that we'd want to do for the pediatrician too, is how can the pediatrician best get them connected with genetics as well, and then what should the pediatrician be looking for in terms of signs and symptoms, and to not dismiss any of that based on, the race or ethnicity of the child.
So I'd just like to comment that pancreatic enzyme replacement therapy and supplemental salt are very safe.
Agreed.
And presumptive diagnosis for a child who is not growing, has GI complications, or, even in some cases proactively, should be used as a bridge. You don't need a full, yes, we all have to do prior auths for everything we ever prescribe, but this can be done. It can be an effective bridge, and then a child is treated and it can be withdrawn. So I just like everyone to keep that in mind.
Yes, I definitely agree. Thank you.
Thank you. Great talk. And I know this data was for babies who had one variant identified. I'm wondering if you saw similar delays for those who needed a sweat and had 2 variants and presumably had CF. And if there was not that difference, it's maybe benefit of more education to the primary care physicians about the limits of newborn screening.
Yes, I chose to exclude those 2 variants specifically because in our center, the sweat testing location is not in the same building as the clinic, and so sometimes they'll come for their clinic visit if they have 2 variants, and then the family, everyone is on the same page that this is CF, and then the family doesn't really prioritize coming all the way back to Atlanta for the sweat chloride test at another time, and so sometimes those sweat tests may be months down the road, just kind of at the family's convenience. So I excluded them for that reason, to not sway the data a little bit. I think that is something we're trying to work on from the other side of things, kind of, by trying to expand our variant panel on the newborn screen so that we get more of those 2 variant pickups so that they can be immediately referred to the CF Care Center and be able to skip the step at the sweat test. So we're looking at it from that end. But that's why I chose not to include it in this data. But I think if we can pick up more 2 variants in the newborn screen anyway, then that would help in everything overall.
Yeah, absolutely.
For those who submitted questions in the app, we'll ask Brittany to respond to them in the app as we have run out of time, but there's a lot of interest. So thanks for coming.
All right. Thank you all. Thank you, Brittany. So next up, I'd like to introduce Dr. Tiana Milanich. She is a pulmonary physician at the University of Washington Adult CF Center, an acting instructor in the Division of Pulmonary Critical Care and Sleep Medicine at the University of Washington.
Good morning, and thank you so much for the opportunity to share some of our work evaluating barriers to enrollment in a large multi-center study of lung transplant education. I have no disclosures related to this presentation. I am funded by the CF Foundation both for grant funding and travel funding. So I want to start by giving you an idea of representation in CF clinical studies. We know that the people enrolled into CF clinical trials do not represent the overall population with cystic fibrosis. A study done by Goss et al. In 2006 explored the demographic information of clinical trial participants through the CF patient registry, and found that participants are more likely to be white and to have private insurance. A study done by Megan McGarry later on in 2016 found that of the trials that reported race and ethnicity data, a quarter included no minoritized people with CF. These are some unpublished data from work that we did this year, comparing the enrollment in CF Therapeutics Development Network modulator studies to an overall eligible population of patients at the same centers where studies were being performed in the patient registry. And this was from 2012 to 2023. And we found evidence of lower rates of enrollment for both Black and Hispanic individuals with CF, even after we accounted for things like clinical, demographic, and other important social variables. This table gives you risk ratios for the enrollment by race and ethnicity for the CHECK study, which evaluates sweat chloride tests after modulator starts, and the PROMISE study, which looks at FEV as well as other clinical variables after starting modulators. And we did find evidence for both lower enrollment for both Black and Hispanic populations. Now, why is this important and critically urgent? I think we all know the ethical and equity argument behind this, but in CF specifically, participants in modulator trials, for example, had access to life-prolonging medications years in advance of the general population. We also know that minoritized communities and people with lower SCS experience a greater burden of worse health outcomes. Clinical studies give us important safety and efficacy data that we should be able to generalize to an overall population. That overall population in CF has a growing number of minoritized people. As of 22, 10% of the population is Hispanic, 3.5% are African American or Black descent, and 43 are Medicaid insurance. But what does improving diversity really mean? It extends beyond race and ethnicity to include socioeconomic status, language, geography, gender and sexual identity, and a number of other facets of personal identity. And so our study I described today aimed to understand why people with CF from minoritized, from populations with historically lower participation rates in clinical trials declined to participate in a multi-center study, and also explore the demographics of those enrolled and declined. The study I described is Lung Transplant Ready CF2, which is a randomized clinical trial that evaluates a newly developed lung transplant education website called Take on Transplant to an existing attention control in the unos.org site. The overall goal was to determine the effect of the education website on preparation for transplant discussions. Take on Transplant was developed alongside people with CF in response to information needs expressed by people with CF. It features up-to-date guideline-based information and includes personal CF patient stories. Generally, we aim to facilitate shared decision-making between clinicians and patients. Lung Transplant Ready CF2 evaluates the Take on Transplant tool, enrolling from 9 clinical trial sites in the US. The study can be done entirely virtually and remotely. This graphic shows you the 6-month protocol, including multiple surveys as patients access one of 2 educational websites. At the end of the study, patients have access to both sites. Importantly, the study includes access to Wi-Fi hotspots and prepaid data if needed to improve access to the study. Those eligible included those who would otherwise be having these transplant discussions based on lung transplant referral guidelines. That includes people with CF with an FEV1 less than 50%. We included adults who spoke English and Spanish and otherwise didn't have a history of lung transplant. Now, our enrollment focused on enrolling what we called communities of concern, which are populations with historically lower participation rates in clinical studies. That includes one of the following criteria: Medicaid insurance, minoritized race, Hispanic ethnicity, or high school education or less. Our goal was to enroll 33% of the study population from these communities of concern. Our strategy for inclusive enrollment involved a number of things, including approaching all eligible patients, so universal screening protocols, discussing the reasons why people declined and exploring the barriers to enroll, and then reapproaching patients who initially declined due to time constraints or logistic reasons, as that can change over time. We explored reasons for declining at all 9 sites. Those were recorded as open-ended responses, and the UW team categorized those responses using content analysis. We also provide descriptive statistics summarizing those who enrolled and those who declined. So this is some of our enrollment data thus far as of September 2024. The solid blue line gives you the actual overall enrollment compared to the dotted blue line, which is the expected overall enrollment. And as you can see, we're on target, enrolling 79 patients as of September of this year. The orange solid line gives you the actual enrollment for communities of concern, which is consistently greater than the orange dotted line. And we've now enrolled 46% of our study population from communities of concern. This gives you some of the data for everyone included, which includes those enrolled on the left versus those who declined participation in the study. Generally, demographics are fairly similar as far as age and sex. I'd like to point out that 5% of our enrolled population was Black, African American, or Afro-Caribbean descent, and 8% was Hispanic ethnicity. This is data specifically for those in communities of concern, and we compare enrolled and declined here, but I specifically want to point out that the largest criteria for belonging in these communities was Medicaid insurance and high school education or less. And we also give you race and ethnicity data here as well. Now there's 2 comparisons here. First, we compare individuals not from communities of concern to those from COC, and then we further divide those who enrolled and declined. We have 3 major points on this table. 1, those individuals from communities of concern tended to be younger, they were more often female, and they had a general trend toward lower lung function. And if you notice the far right box here, those who declined from communities of concern had generally lower lung function as measured by FEV1. Now, to understand the reasons for declining, and this is based on our content analysis, we found generally 5 categories. People cited that they cannot commit to the time commitment, they weren't interested in research in general, they weren't interested in lung transplant as a treatment option, and they weren't interested in the study about lung transplant. Other includes categories where people didn't really give a specific reason for not participating. I want to highlight one difference, and while these numbers are small, I think it's important to highlight. Individuals from communities of concern tended to cite that they were not interested in research in general as a reason for participating, and I'll go into that later on in the presentation. So ultimately, we had success in enrolling populations that have historically lower participation rates and enrollment rates in clinical studies. We enrolled 46% of people from communities of concern, made up largely of low socioeconomic status and high school level education. Importantly, 5% of those enrolled were Black or African American race, which, as you remember, is greater than expected based on registry data, and I want to say vitally important, especially in the context of lung transplant and access to lung transplant. And finally, we found that a lack of interest in research in general that was more common among communities of concern. So what did we learn? It's so vital to ask everyone who is eligible. We also learned that it's important to understand why patients decline participation and to collect this data in order to be able to reapproach those who initially declined for time constraints and logistic reasons. But what's next? Because I really think it's vitally important to focus on the representation of Black and Hispanic people with CF in clinical studies. So we're currently, separate from the Take on Transplant study, doing semi-structured qualitative interviews among multiple CF centers. And these interviews explore the perceptions of clinical trials, people's experiences in being approached or not approached, and patient-centered solutions. So I'm going to give you just a quick an idea of what we're finding and our preliminary findings in this qualitative study. There's a few preliminary sub-themes along with exemplar quotes that we have. People are citing strict eligibility criteria as a reason for not being approached. And this includes narrow inclusion criteria, even outside of the context of modulator studies. One participant said, "Usually it's the mutation requirements. I never get told, even if there's clinical trials going on, to sign up." Another theme is that of racialized experiences and how those affect trust and trustworthiness. And importantly, this is more often in the context outside of CF clinics. So places like the emergency department and the hospital, where people don't know their providers and their providers don't know them. One participant said, "And I feel like me being a young Black woman, I feel like a tiny girl when I'm in the hospital. Like sometimes doctors don't take me seriously." And this idea of not being taken seriously was actually very prominent among our participants. There's a theme of intersectionality, which really references that people carry multiple identities, which can affect their ability to access care, and also more importantly, whether they're told about a study. One participant said, "I wonder if the way that I present in terms of asking questions, if that changes the way that I'm received and the information that is shared. Is it a race thing? Is it an education thing?" This is saying high or low education, along with race, can affect whether somebody receives information. And I think particularly prominent in cystic fibrosis is the theme of isolation. People say that they're the only person of color at their center, or I don't see anyone that looks like me at their study site, whether it's staff or other patients. One participant said, "I'm a minority within a minority within a minority. Because I'm Black and I have CF, it just feels lonely." Another said, "When you're doing these kinds of clinical trials, you can feel very alone because you're a test subject and they want to keep you separate and isolated." And finally, we're seeing a theme of a need for more information and transparency. And this is specifically within the context of risk-benefit discussions. And people say things like, "I want to hear more about the benefits for me and my community." And simply put, one participant said, "But when not enough information is given, I'm not going to participate." So what we're learning is that there are addressable barriers to equitable enrollment. There are clear information and support needs that can be addressed. And it's vitally important to engage minoritized communities in formulating these solutions. And with that, I want to thank the co-investigators for our lung transplant ready CF study, along with the centers and my incredible mentors from the University of Washington. Thank you so much.
Just a reminder, you can come to the mic for questions. You can also submit them in the app.
There's a question from online. I think you spoke to this a little bit, but have there been research or questions on why participants may not have declined outside of time in relation to Black or African American mistrust of the medical system due to historical medical trauma, such as a Tuskegee medical experiment?
Yeah, and our the qualitative interviews that we're currently conducting explore a lot of that, and we specifically ask about a kind of awareness of clinical trials and how people perceive clinical trials, especially within historical contexts, and people definitely reference that. I want to generally reframe the conversation away from mistrust and frame it as trustworthiness based on our kind of the care that we give. I think really the solutions are going to be integrated in kind of one of two things: being trustworthy, and I think understanding some of these motivations is going to be really important. People definitely reference these historical atrocities and injustices, and are definitely aware of them. A lot of people have enough trust in their CF clinic generally to kind of that's not in the forefront for them. But that's why one of the themes I highlight is the theme of racialized experiences outside of the CF clinic. When people experience kind of like ED providers or people they don't know, kind of saying things like, "You have CF," and they're surprised that they have CF. Those experiences are kind of on top of this historical context really influences people's perceptions of overall care and including clinical trials, specifically because they're so vulnerable.
Hi, great presentation and really rich, important data. One of the evidence-based practices in recruiting special populations, particularly minoritized people, is to have a trusted person recommend that they consider this study. So in CF teams, that may be their provider, that may be another person, but to what extent was that practice implemented in your recruitment for this study?
Yeah, we emphasized kind of physicians introducing the study, but I think it's highly variable among the 9 trial sites, and we didn't specifically focus on that as far as equitable enrollment.
So I really commend you and agree with you. Try and get information on why people decline, but that would be another great thing to study because it has been studied and it's been shown to be effective in many minoritized populations. Thank you.
Thank you. And I agree, and that's also what we're finding in our qualitative interviews. People are saying they're much more likely to participate if their physician, their trusted physician, recommends a study.
Another question from online. How do your findings compare to studies in other populations regarding the interest in research in general among minoritized populations? I'm curious in particular relating to general studies, not in a population with a chronic disease.
They're similar. I think the people having CF specifically, as the question is alluding to, is a huge factor in people's experience and outlook. And I think that's really the main difference kind of between among studies outside of CF and the work that we're doing. As one of the, I use this quote that our participant said, the idea that they're a minority within a minority within a minority, that there's so few people who look like them and also experience the disease they're experiencing. And that's why we're doing this work, is that there are really critical differences in CF compared to what we've already found outside of the CF population.
I'm going to ask one more question in regards to just really the key takeaways that you want in terms of how does the research team, how does the CF team, how would you introduce research to people who may have never participated or may have some of that mistrust? What are some of your strategies you would want to take away?
Yeah. I think first to be very aware of the needs of the community that you're serving, because what we're finding in our interviews is that it varies based on people's experience. For example, Hispanic and Latin communities, it's much more important for somebody to speak their language and be culturally aware and understand their family systems and family dynamics and how those impact whether they can access care. And that's different than the experience of somebody, for example, who's Black or African American race, who potentially experiences racialized experiences much more commonly than, for example, Hispanic communities. So I think the biggest takeaway is understanding the person who's in front of you, and kind of, as we were talking about in the implicit bias training, understanding what potentially their experiences is and what's important to them. If it's a translator, if it's somebody who shares their culture introducing the study and helping them feel comfortable that way. If it's an understanding of some of the biases they experience, kind of really just understanding the person and the specific patient in their life, their lived experiences.
I have one more question. So I'm wondering, talking about key takeaways, are there things that you would recommend either on an individual or an institutional level for solutions for trying to recruit individuals of communities in concern?
Yeah, and that's exactly how I would frame it. I think a lot of work in health equity is framed in multiple levels. I do think a lot of, so kind of the idea of individual versus institutional level and study level solutions. I think one emphasis is not framing the individual level solutions as deficit-based approaches and instead framing them as what are the needs of the community. And funny that you asked that question. I do have a slide about solutions. So these are just a few that I thought that I included. Now, I think these are historically studied approaches. So these are what we know based on evidence works. And there's a variety of kind of individual level interventions that we can do. Honestly, my biggest takeaway for solutions is engaging communities. And that type of engagement is going to vary based on the study. But I think every clinical study that involves people should somehow engage those populations that you should center your work around. Whether that is on one end of community-based participatory research or a different type of patient-engaged research, I think it's really important to just include that into your studies and factor that into every kind of clinical research we do.
Can you turn them?
The foundation has responded to those and is about to be responding to an FDA plan on clinical trial diversity. A lot of what you said was taken from a lot of studies and experiences of iterating how important it is, but also how culture and they're not the official line. Some of the requirements proposed feel a little more robust, if you will. And so a lot of our comments are really reflecting the need to you can read much more as the comments are submitted. I can soon, but they'll be on our website.
Thank you so much.
Thank you.
On behalf of Melissa and I, we really want to thank all of our speakers for sharing their incredible bodies of work, and for all of you for participating. In the spirit of improvement, please give us feedback. We really are excited about the future of equity in action. Thanks.